Good morning to everyone and welcome. First of all, we want to apologize for the delay. We've had some technical problems, but now we are going to start. It's a truly pleasure to have today here the opportunity to discuss the topic that resonates deeply with all us, mental health in our profession. My name is Gemma Ortiz. I'm an internist and a past member of the subcommittee of the ECG group. We are mainly focused on developing personal and professional skills. I'll be moderating this session. First of all, I want to sincerely thank you for taking time to join us. Your presence here shows you how much you value not only your patient's well-being, but also your own. This webinar has been organized because we recognize the growing challenge that young internists faces. Among the most pressing concerns is burnout, something many of us felt at some point of our careers. Because many reasons: workload, overcrowded emergency rooms, endless bureaucracy, inefficient management, and along, etc. This pressure can weigh heavily on us, and there are not these problems in my country or maybe in your country. I think it's a global real problem. These realities are something that can concern. So today we are delighted to have here with us Dr. Tolchinsky. He is the head of the department of internal medicine in Badalona, but also he's the secretary of the board of Barcelona Medical College and the coordinator of EFIM program, which supports physicians facing mental health challenges. His long experience and dedication in his field make him the perfect person to guide us through this important conversation. So once again, welcome and thank everyone to being here. And without further delay, I'm very pleased to hand over Dr. Tolchinsky. Doctor, the floor is yours.
Hello, everybody. Thank you, Gemma, for the presentation and for the invitation to you and all your team. I'm also delighted to be here this morning. I will try to go through this topic in a way that doesn't generate bad feelings about what being a healthcare professional, an internist nowadays, because obviously talking about mental health and thinking about us being posed to a situation of potential risk of losing our mental health is something that might not be really cheerful for a Saturday morning conversation. But I will try to explain from a chronologic and bottom-up perspective how we ended up talking about mental health and why physicians in general and healthcare professionals are worried about mental health in our daily practice. I will share my presentation. Will take just a second. Okay, can you all see it? Okay, we'll talk about challenges during our medical career. I will give a perspective on our mental health, and I will begin with talking why I am presenting this session today. Okay. I'm the head of the internal medicine at Badalona Serveis Assistencials, as Gemma said, but I'm also the elected member of the board of the Barcelona Medical Council, which is an institution that I will try to explain, because you all know what a hospital is and a medical team is, but Barcelona Medical Council and the institution that it represents is not something that you are quite familiar with. I am also a proud parent of 3 teenagers, And Gemma said that I'm also the coordinator of the Galatea Foundation, the PAIN program for physicians with mental health problems. I have no conflict of interest to disclose, and I will start to explain what is the Barcelona Medical Council. It's an institution that you can compare it with other institutions like the BMA because it represents and advocates for physicians, but it also offers services to our physicians in our region. But one of the main reasons the Barcelona Medical Council exists is that it's a regulator, and it self-regulates the profession just like other institutions like the GMC that's well known in Great Britain, for instance. So we have to talk about what does it mean to self-regulate profession and how we will end up talking about mental health and self-regulation. It comes from social contract between society and professionals, healthcare professionals, where we are granted with a status that we already lost on the way, respect that we don't find it all the time, autonomy to practice, depending on where you're practicing. But the privilege of self-regulation is something that is really bounded to our profession. Privilege comes from two words. One is privus and other legis. That means we dictate our own laws as professionals, and hence it means that we have to do some things to assure the population that we are regulating who is practicing correctly and who is practicing incorrectly, so as to protect the public. What do we do as an institution to regulate our profession? Well, we certify that everybody who is practicing has a degree, and we list it publicly so everybody can see it. We issue documents and policies with guidance to professionals, and we investigate and apply disciplinary measures when a physician really is practicing in a way that is dangerous for his patients or the population. But professionalism and self-regulation is a privilege, and also it's a burden, because it means that we have to be really aware of how we self-regulate our profession in a way that we maintain the confidence that society has in our own profession. Maybe some of you might recall or remember or heard about how the GMC lost the privilege of self-regulation, and because of the lack of compliance with the responsibility, the GMC is not regulated only by physicians, but also by laymen. And that was, I consider, a loss for the medical population in Great Britain. But what does this have to do with mental health? Because we're talking about regulation and profession and society, but we came here to talk about our mental health. Well, this document, this article in JAMA in '73 started talking about sick physicians and the fact that many sick physicians might be impaired. Being impaired means being unable to practice medicine within the reasonable skills, safety, due to physical, mental, or addictive issues. That brought this medical society in the US, also in Canada, and other countries like Australia, to start opening programs for physicians with mental illness. And that brought us to a situation in which we started analyzing, are we doing the right thing towards our colleagues, physicians who are unwell, and what works, what doesn't work. You see this editorial from '88 in the Journal of Royal Society of Medicine, asking ourselves, measures adopted in Britain and North America to deal with the problems. And it analyzes if really all the things we're doing are really correct for our physicians. But we have to understand first, what are we talking about? Are we talking about mental health? Are we talking about mental illness? It's not quite the same. Mental health is a state of well-being, being able to cope with normal stress in daily life and to work productively and can contribute to our communities. It's not merely the absence of a mental illness, and you also have to be able, in that state of mind, being able to cope with stress effectively. So what is and what isn't a mental illness? Well, when you have a change in your pattern of thinking, of feeling, or behaving that disrupts or interrupts our ability to function, mainly to maintain our personal familiar relationship, functional and social settings, to perform at work or at school, to learn the expected how expected level to age and intelligence, and participate in other important activities. But it's not always clear when a change of mood or thinking really becomes a mental issue problem. Okay, when you have a depressed mood that continues to distress or gets in your way in your normal functioning, that might be beginning to be a mental illness. But you have real categorized mental illness, like you can really diagnose somebody with a major depression or schizophrenia or bipolar disorder or other illnesses when you have a real important functional impairment. That's where it links with what we're worried about, being physicians, being fit to practice, and have a functional impairment that doesn't enable us to think properly. But when you mix mental illness and regulation, they don't fit quite well together, because when we started our programs, and I'm going back to that paper in '88, and where they analyzed what was going well and what was not going well, trying to help physicians or trying to self-regulate our profession, you can see some articles that are pointing that medical licensure and questions and physicians are reluctant to seek for help, and you see what are the barriers to look for help in mental health conditions for physicians, and that people are reluctant to have some type of record on mental illness in their record as physicians. So it's not easy to self-regulate. It's not easy to help physicians who are unwell and being a regulator. That's why not all the countries, not all the programs that have physicians' health programs are related directly to the regulator, and that makes the program that we are running really unique in that sense. The importance of this program is that the issue that we're dealing with is the competence of physicians that can be affected by psychological problems, addictive behavior, such as drugs and alcohol, and psychotropic medication. Nearly 10 to 15% of physicians will develop in some moment in their lifetime, profession, some type of mental illness or mental addictive behavior, and it can affect patient, and it can affect family and their work environment. And that might resonate to you, that when a physician is unwell around you, it generates a burden in the team or to physicians, to patients. That's why in 2019, the American College of Physicians tried to clarify what should be the standard to deal with physicians with impairment, and focus on rehabilitation and reintegrate them into medical practice while ensuring patient safety. To make it short, it's about preventing instead of punishing. It's about rehabilitation instead of banning from practice. It's about persuading versus coercion that it doesn't work. It doesn't really make our medical population seek for help. It more than 25 years ago, the Barcelona Medical Council that heard about the article in '73 and the beginning of the programs in Australia, in Canada, and in the US started their own program that's called PAIM. That's the PHP program for in Catalonia. In Spain, the rest of Spain is a PAIME. It's a specialized mental health service with really top clinicians and our own private clinic. It's free. It's founded by the health department and the medical association at the beginning. It's a really easy access, highly confidential. There's a special procedure to change your name when you go into the program. It has, as you will see, high rate of self-referral from physicians, and it promotes self-regulation, since we introduce in our ethical oath that if a physician is unwell to practice, he must look for help. And if you detect a colleague that is unwell, he must look for help too. You must help him and you must refer him to help. If he's reluctant, you must communicate it, because it's protecting our population. 3 years afterwards, we founded the Galatea Foundation that included all other healthcare professionals like psychologists, pharmacists, nurses, and in the last years, we've incorporated also social workers and physiotherapists. So we have a really cohesionate healthcare sector with a very specific program, very highly professionalized, and that answers to the necessities, to those physicians who are at high risk of mental health. The access to this program is mainly voluntarily, going directly to the Galatea clinic, and it's confidential. We protect the identity of those who ask for help, and it has a therapeutic and rehabilitating goal. It mainly focuses on professional self-regulation. That means that the professional that detects that he's unwell is regulating himself by seeking for help. The regulatory pathway is reserved only to those cases with very severe mental illness, with a situation where the physician is not aware of how unwell he is, or when the consequences in his environment alert everybody and they report him to our program. It requires an evaluation. It has also a therapeutic and rehabilitating intention, and that's how the Barcelona Medical Council as a whole self-regulates profession in a situation of mental illness. Obviously, if a professional is seeking for help by himself, but the severity of the disease or the lack of awareness of the risk that he's posing for himself or the patient, the psychiatrist that treats that professional might report him to the Barcelona Medical Council. But as long as that physician is seeking help and doesn't have a really severe mental health problem, he would be unaware. The Barcelona Medical Council will be unaware of him being seeking for help and treated by the program. Obviously, in really, really rare occasions, we have to apply disciplinary measures, mainly in physicians who go to work under the effect of alcohol and other drugs repeatedly and not complying with the requirements of the Barcelona Medical Council. I'll give you really quick numbers. Last year, we had 225 new cases. Most of them, 223, came voluntarily. Only one came induced and one came with a confidential communication. Most of them are mental disorders, adaptive disorders, mild depressions. Alcohol accounted for 4 cases, other drugs such as fentanyl or cocaine, 10 cases. Dual pathology, that's when you have a physician with mental disorder and consuming drugs. It accounts for 18, and other addictions, just 1 cases. In 2023, we had almost 1,000 active cases on follow-up, but only 25 of them were supervised by the Barcelona Medical Council. Here you can see the graph where the number of voluntarily in referrals to the program increase year after year. This ends up just before COVID began, this graph, but it continues to increase the year after year. That's because there is a lot of confidence that the program is helping many of our colleagues in Barcelona. We had 54 physicians that had to be admitted to treat their illness, and we are happy to have a very high quality clinic that really helps physicians in really extreme conditions. That doesn't mean that they have to be reported. The severity of the disease, when it responds correctly, doesn't need to be reported to the regulator. So overall, in the last 25 years, more than 80% of physicians who come asking for help are for mental disorders. The other 20% accounts for problems related with substance use disorders. But there are still barriers in our medical society in general. Physicians all over the world behave more or less the same. They don't have their own physician. They ask for help to a colleague in an unstructured way. We're not really good we're really good patients in general. You can see here a list of, in this article, they elaborate what are the barriers to look for help. Well, the perception about mental health, especially stigma and the perceived stigma. They're worried about the confidentiality, and since we are working really hard to maintain confidentiality, protect identity, the career implications, because in many countries there is a really harsh behavior by the regulator towards physicians with mental health. This is changing in the last years, but it has been really difficult to make regulators understand, especially in countries like the US and Great Britain, where physicians had really bad consequences for mild mental illness. The waste of time they feel they don't have to seek for help, the accessibility and awareness. That's why it's important to promote and publicitate these programs so they are well known and people know where to go. And the culture around medical society, around the expectations about differences in generations. Probably my generation is not so open about talking on their mental issues. Younger generations are a bit more open about that. Female population is more open and more prone to ask for help. Male population does not ask for help so easily. But this is just the top of the iceberg. These are the ones that are looking for help. There are many other physicians that are unwell or at risk of being unwell. That's why the Galatea Foundation started a lot of research in different areas of our professions and different healthcare professionals to know about our lifestyle, our hazards at work, and our behavior towards determining some of the risk factors that we face daily. So what is our situation? This is a summary of many of the studies we've made with medical students, residents, physicians from different backgrounds, and also with other healthcare professionals. As you can see in this graph, you have medical students in the left end with a high risk of poor mental health. We're not talking about having mental health problems. It's a scale, Q12 element scale, that we're using to compare with general population. We use this scale because we have the reference of public health studies with general population, so we can compare how during our lifespan this evolves in our profession. So you can see medical students are at high risk of poor mental health, especially female students, and that declines after you manage to go into your residency program. That means that you're less stressed or less prone to have mental health problems, but it goes with an increasing pace during the 4 years or 5 years residency, and it almost reaches the same levels as the students, but afterwards, when you get to your practice career, the levels go downwards back again. And it happens, for instance, we studied specifically pediatricians that are that asked for help during a certain period, and we assessed how the situation went in their population. But you can see pharmacists, nurses, and dentists, for instance, have or social workers have high risk of poor mental health, and that's something that has to be analyzed on its own. When we talk about alcohol consumptions, you know that alcohol might be a way to cope with stress. We see medical students, mainly male medical students, having a really intensive use of alcohol, especially binge drinking during weekends. And this fortunately declines a bit during the first and second year of the residency. And we still don't go back to levels comparable to general population you see on the right hand. You have to know that you must know that in Spain we have it's a cultural factor of the consumption of alcohol is well spreaded. So being above the average of the general population, those are really high numbers. On the other hand, the consumption of hypnotic and tranquilizers, we're not so above the general population, but you must know that Spain, and especially Catalonia, has, compared with the rest of the world, one of the highest rates of consumption of tranquilizer, benzodiazepine especially. So there are still numbers that are really high. You can see that there's a different patterns. Female students have they choose more to consume hypnotics and tranquilizers instead of alcohol compared with male, and this is maintained during the whole professional career, but it's not quite the same with pediatricians or, for instance, dentists that have well, it's a profession that has a larger proportion of male professionals. But healthcare professionals have problems with mental health, and it's something that it's being published and research all over the world. You can see that in this one perspective search in PubMed, you can see that there are more than 3,000 articles, and you can see in the graph here on the bottom left that you have an increased rate of publications of papers related to it. This one analyzes what are we publishing specifically, well, more related to the North America and medical population, but you can see this increasing rate is maintained also here. The research is mainly in the US, and it concentrates on physicians and residents, also a bit on medical students. And what they research and publish the most is about burnout and stress, also about suicidal behavior and depression, and psychological harm and distress. Well-being and wellness is another way to express the worry about being at risk of burnout. most of the publications are around solutions for mental health problem, although it's not well characterized that all over the healthcare systems around the world, the solutions might work the same way, because healthcare systems are not quite the same. The population also isn't the same. So this is something that has to be analyzed on its own. But the prevalence of mental health problems is one of the main publication issues. The causes underneath mental health problems and the effect of mental health problems on physicians and patients is also an interesting topic that has been published widely. There are other programs around Europe. You can see we've been talking about our programs, but its reality is that there are other programs around Europe. I must point out that Great Britain is the one that's having the largest program in numbers of physicians treated, and it has been growing really fast in the NHS. It expanded over the last 15 years from being a program in London to now disembarking in Scotland. Vilasana with Modum Bad is one of the most known programs too. And there are other programs in the rest of Europe, but they're not really so expanded in their countries and not so well known. So you can see that talking about mental health problems in medicine is a very broad concept. We started talking about impairment, mental disorder. We haven't talked about suicide, but that is a consequence of mental disorders and burnout. There are some problems related with addictions, that how it started. One of the most important parts of the programs in the regulatory perspectives all around the world are centered in addictions. Some countries like Germany have some specific programs related with addictions and not treat other mental health problems. So I'm leaving for the end burnout and wellness, that these are complementary concepts, and I will try to explain why. You can see that you can look at it as from different perspectives. And we were talking about the individual factors that are affecting our physicians and how individually they can seek for help and receive treatment and rehabilitation. But this is really a professional problem, and it's something that it's happening inside our organizations. And regulatory issues are not so important in the problems that are happening inside the organization. Regulatory issues happen when you get to the point where mental illness is so severe that you have to intervene. But in the end, it's a social problem, because healthcare professionals are a really important part of society, and the relationship between profession and society is one of the things that behind the cornerstone of our profession. So burnout is going to be this part of the presentation focus, and I will try to explain what burnout is. If anybody knows, Christine Maslach is a psychologist that in the early 70s started investigating about the burden of what's happening to professionals in their work environment. And she came out with the term burnout, which is a psychological syndrome that emerged from a prolonged response to a chronic interpersonal stressor on the job. That means this is a professional hazard, and it is expressed, or the symptoms might be, or they call it dimensions. It's an overwhelming exhaustion. It's a feeling of cynicism. It's a behavior also. And it's a detachment from job, or a sense of ineffectiveness and lack of accomplishment. That means that personally you don't feel satisfied with what you're doing. The underlying causes of this might be the workload, an unmanageable workload that forces you to give up other tasks and consider important, even if it's your personal time. Lack of sense of control of what you're doing in your daily job, the lack of an acknowledgement, be it symbolic or economic, the fact that you're integrated or not in a community, which is related to the last point, which are values, when you share the values inside that community, and the feeling of unfairness, either professional or from patient, might lead also to emotional consequences with psychological detachment from work. Some say that it's the electronic health record era who started everything. I'm not quite sure it's about the electronic health record itself, but it probably has to do with the management of the data and complying with the electronic health record necessities to fill in more and more information that drags some physicians to burnout. So burnout is not a diagnosis. Burnout is a symptom. Physicians who are burnout in one organization, in one work environment, or working with some type of patients might not be burnout in another environment. That means you're not taking the problem with you. In fact, who is to blame there? Well, it's a mismatch between the professional and the workplace. Okay, what to represent in this picture, that everybody thinks that the other one is to blame, probably is the lack of match and the lack of ability to work together and find a way to make things happen in our daily practice. We can measure burnout. In fact, Christine Maslach invented the MBI, that's the Maslach burnout inventory. And there are other metrics that you can use with their good and bad things about how easy, how expensive, how expensive it is for other healthcare professionals. So the thing is that you can measure it, but you can measure it as you measure temperature. You're not diagnosing what's underneath that temperature. You're diagnosing a state in your organization. Okay, I will skip this video because we had some technical issues. So I'm sorry, we will try to skip them. In this video, they were mentioning one concept, that is resilience, that you might have heard of. Resilience is our capability to adapt to difficult challenges in life and experiences, especially through mental, emotional, and behavioral flexibility. That is true, and it's necessary. Everybody has to be resilient, but you cannot work in a work environment where resilience is the solution to everyday practice. It's the solution for a situation in which you're under stress and you go back to normal situation. This article from JAMA was from a few days ago, a debate about the cannery and the coal mine for the healthcare affordability. I don't know if you heard about the cannery in the coal mine, but they used to use a cannery to detect if there was higher proportion of toxic gas or lethal gas. The cannery would die rapidly, so the workers knew they were under a risk and they would go out of the mine. Medicine is the one profession when the cannery dies, you look for a more resilient cannery. But everyone is suffering burnout? No, the proportions of burnout are very varied, and we will see some numbers afterwards. But those who are not burnout are somewhere in between the line that goes from burnout to engagement. And what is exactly engagement? Engagement is a state of mind, a psychological state of performance that is a disposition to be positive, to be proactive in your organization and to get involved with projects and committed with what you're doing. So how much burnout is there? There are two studies, for example, I'm presenting some numbers. These are before the COVID period, one of them, and the other one as afterwards. But I'm not going to relate to COVID because it's a very specific moment in our medical history recently. But the numbers are that we have a high proportion of symptoms related with burnout, but there's a really big variability of the proportion of healthcare professionals who are diagnosed or they are with the symptoms of being burnout. So it's really difficult to say, depending on how you measure burnout, how much is there. You can say there's probably between 50 to 30% of physicians burned out in our organization, but it varies really too much to be able to say one or another number. This article I wanted to share with you is, well, Tate Shanafeld is one of the experts who published the most about burnout and well-being. And this article summarizes really well in some slides I will show you the different eras we had of perception of what mental health meant to medical society and our profession. You see, there was an era where the dinosaurs existed, where everybody expected us to be perfect with no limits on working hours. Self-care was something that was not even in the agenda, and you really might have felt isolated in when you had some issues. Everything was focused on being able to perform, and the era unfortunately ended some years ago. And now we're in a era where we're transitioning between the well-being 1.0 and 2.0. I will try to explain. We began with the hero-like qualities, that is being resilient, being the main focus, and everybody, all the organization were offering courses of well-being, of resilience, of self-care, of being able to cope with the workflow. And that led to a lot of frustration, but because people said, okay, I'm fine. I'm thankful that you're giving me a space to have to take care of myself. But what I really need is not having to take care of myself in my working hours and being able to work without feeling too stressed and too burnout. The goal where we're heading to, or how it should work, is to concentrate on human qualities, on vulnerability, on growth mindset of our professional progression, and integrating what's our work and life environments, not on balancing them. Balancing means that they're separated and completely unaffected one by each other, but the reality is that they are affected, and you have to integrate your working personality into your personal life personality. It's an era of self-compassion, not an era of feeling pity for ourselves. Self-compassion is not being too harsh on yourself when you're not feeling really well. And being able to build a community in which everybody feels safe and everybody feels comfortable when they are not well. And I think this last point is one of the most important because it connects with one thing we've mentioned before. It's having a purpose, having a meaning in everything we do is really important, because that's what makes us feel engaged with our work and not detached from doing things that we feel they have no meaning, they have no purpose, and the impact is on the organization and not on the wellness of the patient. But we ended up being in this transition because we began with the Declaration of Geneva, where after Second World War, we solemnly pledged to ourselves to consecrate our life to the service of humanity. I think this, I remember a meeting with Claire Gerada, that's one of the physicians who led the creation of the British the PHP. She was criticizing that this could no longer be part of our ethical oath, because it's too much of a burden for a physician to consecrate his life to humanity. It's okay to be compromised with society, but it's not well to have all the burden to serve humanity. This continued to be that way until 2006. We still solemnly pledged to consecrate ourselves to humanity. But now the draft that they're working on, and I hope this is eliminated from the final document, we have the responsibility to contribute to the health and well-being of the population and serve society as a whole, including future generations. But we cannot take the burden of taking the responsibility for what happens to society no matter what. And from we saw the graph before, slide before, we were talking about personal evolution during that this period. Now we're talking about what the evolution in organization looks like, or we would like it to look like in the end. First, the area of distress, we were talking, now there was a lack of awareness that was a problem. The focus of the institution was its own need. The environment was really rigid, and the problem was really individual. It wasn't a systemic problem. They ignored distress continuously, and they neglected physicians who were under situations of severe mental illness. The physicians and administration worked independently, and everybody did their own job and didn't even think they had to work together. Now we're transitioning in an era of wellness 1.0, and it's about awareness that this problem exists. There's a choice of working in a certain way. Still, the focus was on patients' need only, and we treated distress in our organizations. Still, it used to blame individuals, and there was an adversarial relationship between clinicians and administrators, where what was happening is the other one's fault. And where we are heading to, or we hopefully hope to end up, is an organization where clinicians and administrators collaborate to make the organization work in a way that physicians and patients are also in the focus. So what burnout is, we already heard of. What can be done? Well, from the individual perspective, we must prioritize our personal health by incorporating rest, breaks, and self-compassion, as we said, to our daily routines. But we have to reject the victim mentality, advocating for a change in our organizations and not feeling the victim only, because part of our implication might be part of the solution. Building relationship with the colleagues and having a supportive community is something really important, and integrate identities from personal and professional identity, and not having an inner fight about what am I? Am I a family member, or am I a physician full-time outside the job also. I would like to also focus on some specific concepts. Physicians are really focused on searching success, and really in our daily practice, especially in internal medicine, I would say managing failure in a sense that we're not perfect, but either our diseases we treat daily, our patients, success does not mean cure necessarily, and many students end up seeing medicine as a failure environment, because in medicine, when you study, you have to score the highest in your tests, but in daily life, you don't score so high. The management of knowledge is something that is really important, was really important, but nowadays also understanding our emotions, the concept of endurance, the being able to cope always with everything, has to shift to being aware of our limitations, and that's related to being able to seek for help and not doing everything by ourselves all alone. That means team building, building relationship with other professionals who are helping in our daily practice, and also the transition from inductive reasoning to critical thinking. There's a really interesting article from Ronald Epstein about mindful practice, about being able to reflect on why are we doing things the way we're doing, and what would I do differently in that type of situation if I had the time to think really if this is the best outcome or this is the best way to manage it. What can be done from the perspective of leaders? Leaders, well, they have to incorporate well-being in their mindset through personal practice and organizational policies. You had to engage with staff. You have to take the pulse of what's going on in your team to see if everybody is more or less comfortable with their way of working, with the relationship they have. You have to promote shared purpose. That means to align the organizational values with the personal and the team values that we saw that was very important, and also to support development, the growth, the professional growth of our teammates, and the resilience in training for the staff. And from the organizational perspective, we already mentioned the transition from viewing wellness as a cost center to a strategy inside the organization, especially emphasizing the values, the value of investing in well-being in the organization. That doesn't mean that you have to deliver courses as an organization for people to be resilient only. It means caring about what our professionals need to function in their personal and their professional life inside the organization. Implementing system changes, that means being open to change workflows, to create sustainable workload, and to ensure the coverage during physician's absence and incorporate appropriate breaks. And to encourage teamwork is one of the key issues in the way we work in our daily basis in the organization, and to detect and develop and foster leadership inside the organizations. That's transitioning from one model that began with Berwick, that was improving patients' care and reducing cost and improving health of the population, that what we say in Spanish, bueno, bonito, barato, that's something good, that's something nice, and that's something cheap. That was a triple aim, and we have to go towards the quadruple aim. That means improving clinician experience incorporated inside this wheel, and not only focusing about the costs. That's something related with the organization or the patient care, and ignoring that the healthcare professionals also have their needs. So how can internists contribute to this change? This is the last part of the presentation. I'll try to be go easy on you on this part. It's obvious that there's a crisis, workforce crisis, and a general crisis. In fact, this made it to the general papers. In fact, this is a picture of a strike in Barcelona. The healthcare systems in Europe is a ticking bomb. The causes, you all know them: chronic disease, aging population, multimorbidity, complexity of treatment and frailty, loneliness, and high expectations in patients. Us as professionals, we have a loss of thought of status, the mobility of professionals between different organizations. We have our own goals in the professional and personal perspective. There's a lot of burnout, and the subspecialty narrow view is something I would like to focus specifically, because that's how part of the problem in our medical organizations began, I think. How difficult it is to master all the knowledge and skills necessary to practice in medicine, and specifically to treat patients. From the organization's perspective, the workforce shortage, problems with budgets, and the industrial patient flow, that's that model of fast track where no matter who is treating the patient has to go really quickly inside the organization. The difficulties to find specialists, and the electronic health record, since they've mentioned it in the early articles, I would like to include here. And from a social perspective, poverty, the cost of healthcare system in general budgets in the countries, and the high expectations as society towards our professionals. Well, this paper from the Internal Medicine, the European Journal of Internal Medicine from 2005 was that was the moment where I was finishing my specialty. Everybody was a bit worried about what will be the role of internal medicine when subspecialists began to rise as really strong advocates for their part of the field in medicine, also in academic, from academical perspective, and in healthcare system overall. There was really worried about what internal medicine future will be. But the role of internists in academia, but also in hospital, is really important. And this article 10 years later is pointing about the importance that academic internal medicine offers to transform healthcare delivery and scientific research. And the European Federation of Internal Medicine supported the concept of academic internist and call upon members to construct an academic and internal medicine department in the respective country that was sometimes shrinking. The competences of internal medicine as specialists are really key in nowadays, and they're part of the solution to the problems that we're seeing today in many medical organizations around the world. There's also a short video I wanted to include here, but we will skip it because of the technical problem. Okay. So I would like to, right, we're getting to the end, to focus on this paper where we're talking about what is happening in the near future, what should be happening, and what will be our role. We were talking with Gemma before this session when we were preparing it, and I really think it aligns with what we were talking when we were preparing it. And I was happily surprised to know that there was a paper talking about it. This paper is from 2010. That means we're 15 years afterwards, and we still have to work on it. Basically, we have to adopt the principles of professional behavior. We have to have central roles in our hospital, coordinating interdisciplinary teams, diagnostic and therapeutic care. And we think that medical care has to be optimized, not maximized. That means it has to be patient care, not centered in only what technology and what science can do. It's what the patient needs. The multidisciplinary team is the best approach that I think we can have with patients with many complex problems, and European countries must integrate into the healthcare system the coordination of different medical specialties, because nowadays they're really separated, very narrow view, and they don't fit with the needs of patients. And this article finally says that the internist's wide spectrum of knowledge and skills make them the best suit for leadership in the application of evidence-based medicine and the cost-effective strategies. I really agree with this statement, and I think this is part of the solution to many of the problems we were talking in related with burnout. In fact, we published a few years ago, 2022, about clinical leaders. The fact being a clinician is really important to be a good leader, but we have to integrate the emotional intelligence in leadership. Our organization went through many transformations. The PAIM and the Galatea Foundation through the years developed not only individual treatment, we also developed collective group treatment, also training. And I think that's adapting to the reality and needs of the organizations. And in the last 3 years, we started a leadership program, educational program for medical professionals who will lead the change and transform organizations in the coming years. So, as final conclusions, I would like to say, it's been a quite long presentation, that professionalism and self-regulations are core concepts in our social contract with society, that mental health is a broad problem in medical profession. It can lead to impairment, and it might be a risk for patients and disengagement from our profession. We have to acknowledge the problem, and dealing with it is crucial. Mental disorders need specific and high quality programs. As you've seen, there are many programs around Europe. You should take a moment to know if you have one in your country. And burnout needs prevention, leadership and organizational changes, not treatment. That means that wellness programs are okay, but they're not the solution. They will perpetuate the feeling of being left out in a really risky environment. And internal medicine is in a great position to lead transformation of healthcare organizations and system. I really insist on this because we're all internists. We have a position in which we can make a difference in many of our organizations. And to achieve that, you have to be aware that multidisciplinary teams and organizational leadership is a core competence in internal medicine, and we should look for a way in which this is incorporated in our training programs. That will be all. Thank you for your attention and patience, and sorry for the inconvenience of the technical problems.
Thank you very much, Dr. Tolchinsky. It has been very inspiring, and I guess we are the future to start changing this point of view.
I hope.
Me too. Waiting for some questions from the audience. I may like to ask you something, because I have the feeling that during COVID pandemic, all the stressors we used to have before and now some kind of disappeared, and we were able to work longer, harder, and rapidly changing our point of view. But it seems that at some point burnout trend to disappear, but appear something like moral distress. Can you tell us something under your point of view?
Yeah, the phenomenon that happened during COVID is very specific in history, I would say, and that's why I didn't mention it specifically in my presentation. Moral distress is a concept that it's not usually present in our daily practice necessarily. It's more typical in nurses. Moral distress comes when you feel that ethically you're not doing what you were supposed to do, but you don't have the strength or the power to change what should be done. That happened to many of us when we had to take really, really difficult decisions with patients during the COVID period, because we didn't practice the way we used to practice. We didn't send patients to the intensive care unit because we didn't have any more beds for these patients, and we had to take really difficult decisions. But on the other hand, during that period, many leaderships emerged in organizations. We were managing to change the way we worked because we all had a purpose. We all knew what was our purpose during that period, and having a purpose was something really strong, and the feeling of a community during that period was really strong. Everybody was aware that we had to go to the same direction. It's like a magnet that was orienting all the professionals during that period to one specific task, that is to manage the big tidal wave of patients and caring for all the sustainability issues. And the organizations usually backed up and let clinicians decide what was the best way to treat the situation. So on one way, there was a lot of stress and moral distress, but on the other hand, the perception of burnout was not so strong. It came afterwards when people were really tired and they didn't feel that after that effort, they had an organization that was aware that the way we faced COVID was something extraordinary and we should learn from it. But on the other hand, when we went back to usual normal days with the same patients, and we see that the organizations went back to their typical structure, we felt we lost the purpose there.
Right, thank you. I cannot see any questions yet from the participants, but I have another one. Under your point of view, which are the factors that keep on maintaining a program like PAIM? What makes it stay longer and sustain during this long time it has been going on?
Yeah, there are many factors. There are many programs. I've been through many conferences in Europe and also in America, where many researchers presented experiences of well-being programs, of healthcare programs for healthcare professionals. And they were really based on short budgets that were related to a fee with a short period of existence. That's on one hand. That means that programs were related more to academic purposes than to professional purposes. On the other hand, there's also the fact that when you have an institution backing up behind that program, such as the NHS in England, or in our case, the Barcelona Medical Council, and the rest of regional councils that have adopted this program, It is important because it's the profession itself that holds the importance of the program, and the cooperation we had with the administration was something extraordinary. We had the support of the administration from the beginning, and that helped us to the sustainability of the program. I know there are other programs around Europe that are really affected by the political changes. Not everybody understands the importance of having this program from a social perspective, from an organizational perspective. We've helped some countries build their own program, like in Uruguay, where the National Council issued the creation of the program. But after the election of the new board, they decided to cancel the program. That means it's a cultural thing that has to be built in the profession to maintain the momentum when you create a program and to gain confidence of physicians in your region. I don't know if I answered the question.
Yes, very good. We've got a question from the audience. It's from Dr. Mario Stabile. He says, thank you very much. It was very inspiring talk, and he's got a question. Under your experience, what are the early signs of burnout if we recognize them in ourselves or our colleagues? What do you recommend we do? Who should we ask for help in the first instance?
Mm-hmm. Well, we said that there are three main dimensions in burnout. One is cynicism. That means a behavior in which somebody or yourself, you detect that your relationship with your colleagues is harsh. You don't feel very comfortable with some colleagues that talks in a way that you feel, well, he's attacking me personally and not discussing a patient problem. Or when you feel detached from job, that means that Monday morning is really difficult, or that when you're at your work, you're really asking yourself, what am I doing here? Why have I chosen this profession? Or I might as well being a plumber instead of a physician. If you ask yourself that question, you should ask yourself if you're burnout. Okay. The solution, as you've seen, it's not the same having a mental health problem, a serious mental health disease like addiction or depression. And as I said in early slides, it's difficult to know when a mood is beginning to be a medical issue that has to be treated. Because the way the question is asked looks like you have to ask for help for yourself, but in fact, it's an organizational problem. But it's also true that us as physicians, especially in internal medicine, where we have a very wide field, we don't fit exactly in all positions the same way. I mean, if you like hypertension, or if you like chronic frail patients, it's not the same to be doing seeing patients with one type of disease or another. And the way the organization is set is also important. And maybe you can talk about it with the head of the department. I'm not saying I'm the best head of the department, and I'm not even really good, but I really try to focus on what are my team, how they fit in the position they're working in. That means you have people who work really well in complex environment, and they work really well with a wide team, taking situations where there's rapidly changing issues, and people who work with high loads of patients, but it has to be very structured, and it has to be really straightforward a job. Okay, so we're not all the same. We might ask ourselves if we fit in the position we're in, or maybe we would like to be working in something different. And if your head of department maybe is, you should talk to him and sit and try to understand, what do you see in me that's working? What do you see that's not working? What do I see that's working? And try to work it out together. I don't know if this works out to everybody, but I think it's one way to address that.
Thank you very much. Got another question.
Mm-hmm.
And let's move to another important thing. The opinion of the audience. He says, I think that at least reducing the bureaucratic issues would improve physicians' load. What do you think about it?
That's true. Bureaucracy is something that is not part of our mental structure when we are thinking about patients. In fact, in our organization, one of the residents did a study about the interruptions of our work. When they interrupt you for a clinical problem, you don't have that perception that they're interrupting you because you're still working on a flow of critical thinking inside medicine. When they interrupt you with a bureaucratic problem, you have like the feeling that you have to go outside your clinical mindset and go back to it, and you really feel that it tackles you during your daily job. The thing is that the tools we are using should integrate most of the bureaucratic load and not have to work with it alongside. Some countries, like here in Spain, we have some initiatives to have specialized administrative workers that are working besides us and on our sides and helps us with our bureaucratic load. But it has to be identified what's bureaucracy and what's not bureaucracy, because some papers we do are clinically meaningful and some are not.
There's another question. Dr. Alvina wants to know, what about vulnerability? Do you think it's a good idea to open up the patients about our problems?
Well, first of all, we have to be aware of our vulnerability and be aware of it. But it's not about dropping the problem to the patients. It's about dropping the problem to our organization. They should be aware of our vulnerability and organize things in a situation where you're not exposed. But it's really unprofessional in old-fashioned thinking to be vulnerable in front of patients. But you have to look for a balance. Maybe you should be quite assertive when you think you're not in your best situation to make a decision because you're really stressed, and you say, okay, I'm not in a good situation to take a decision. Maybe I'll have to think about it and decide later. Well, sometimes you're really under big stress. And when you talk about vulnerability as a profession, you have to advocate for the patients. We're vulnerable, hence society needs to understand you have to found the healthcare system in a way that we're not exposed to risks that make you as a population be at risk.
Thank you very much. I think there are not more questions. Maybe we can finish here. Okay. Again, thank you very much. It has been amazing talk and very inspiring. I hope everyone of each of us can take something back home and start doing it on Monday. Thank you, EFIM and ECG Group, to leave us hosting this amazing webinar, and thank you all to be with us. to you.
Thank you very much, Gemma, for inviting us, inviting me, and from the Barcelona Medical Council. We're really happy to share all our experience. And as an internist, I'm really happy and proud to be able to participate in this webinar. Thank you very much.